one of the most common reasons for employees to come in and see you. Probably one of the most common causes is the rotator cuff, but if you don't remember anything else from this talk, just remember the neck or the cervical spine is probably the next most common reason for pain in that area. So don't forget to do a spine exam and/or send the patient for a spine evaluation. So there are a number of different sources of shoulder pain. We can divide them either to coming from the joint. So that would be arthritis, capsulitis, instability. We'll go through all these. The rotator cuff, it can be diagnosis of bursitis or even a tear. The AC joint, where you can also get arthritis. And then we can divide it either into trauma or non-trauma causes. So traumatic tears and both atraumatic tears can both occur. You can have dislocations, which are traumatic, and fractures. I'm not going to talk so much about the fractures today. And then atraumatic causes include inflammatory conditions or osteoarthritis. So just to review a little bit of the anatomy, the shoulder is a pretty complicated joint. So as you can see, there are actually two sets of bones that make up the shoulder. Hopefully you can see my pointer here. So the main part of the joint is the humeral head and the glenoid. And so if you think about the shoulder as a ball and socket, the socket of the shoulder covers it only about a third. So what that means is there's a lot of mobility in the shoulder joint because the bony part of it is only covered by a third. And so there are other things that will help stabilize the shoulder joint, but it's not bone. You contrast that to the hip. The hip is also a ball and socket joint. And in the hip, the socket covers the ball about 3/4 or 75%. So that's why you almost never hear about a hip dislocation, maybe in a car accident or something like that. But with the shoulder, from a fall, the shoulder joint can come out of place. So it's a much more unstable joint. The other part of the bone anatomy that we consider the shoulder is up here, the AC joint. So the A is the acromion, which is a bone coming off of the scapula. And then the C is the clavicle, which is where these two bones come together and make the AC joint. Then if we look at the musculature, so here are the rotator cuff muscles. And as you can see, or you may remember from anatomy, you have the subscapularis in the front, and then you have the supraspinatus right along the top. In the back of the shoulder, and this is looking at the back of the shoulder, you still have some of the supraspinatus, but it turns into the infraspinatus and then the teres minor. If we're looking inside the shoulder joint, so this would be patient's head is over here. Here's the humerus. And now if we take away the subscapularis and look into the joint itself, you have several different structures here. So you have the labrum, which is the lining of the shoulder socket. And then you also have the cartilage. So the tan part is the bone, and this shiny stuff is the cartilage here, as well as in the socket here. So osteoarthritis, again, is wearing down of this cartilage coating. So in doing a physical exam, this is the order of steps that I typically go through. And I think the number one thing to remember is that you cannot inspect the shoulder with somebody's clothes on. So the clothes need to come off because there are many things you're going to miss if you try to do an exam with their shirt on. So the first thing you want to look for is actually look at the patient from the back. So this is looking at the shoulders from the back. And what you can see here is that the muscles are different. They're actually atrophied on the left side compared to the right. We can also look for and this is a little more finer detail, but you can take a look and see if there's any difference in the position of the scapula as well. But I think just for a general exam, looking to see if there's atrophy is very important. In particular, if they're complaining about pain on their dominant side, in general, you would expect the musculature on the dominant arm to be more robust than the non-dominant side. So if they have atrophy on the side that's non-dominant, that's more likely a chronic condition or an acute on chronic condition. So then in terms of palpation, if you're looking at the patient from the front here, I know it looks like someone just threw a bunch of arrows on this picture, but I would say the most important things in general practice to check for are pain over the AC joint. It's very common to get both X-rays and an MRI where there's a diagnosis of AC joint arthritis. The majority of the time, it's actually not symptomatic. The test is very easy to check to see if it is symptomatic. You simply palpate them over the AC joint and see if that causes pain. The greater tuberosity would be on the lateral part of the shoulder, and that's where the rotator cuff inserts. The biceps tendon. So the biceps has a tendon both at the elbow and at the shoulder. At the shoulder, it can also be a source of pain. In general, it's in the front of the shoulder. If a lot of it is just practice, but you can actually feel the biceps tendon in someone who doesn't have a lot of soft tissue in that area. And that also is a very common diagnosis on MRI. The diagnosis will say proximal biceps tendinopathy or tendinitis. And the way to check to see if it's symptomatic is just palpating over the biceps tendon. The lower three structures, I would say the trapezius is probably one of the most common things that I see that people mistakenly self-diagnose with shoulder pain, but it's actually pain coming from the trapezius. So the trapezius is running along the side of the neck here. And it can be caused by shoulder pain, but more often what I see is that there's a cervical spine origin of pain, and the patient is getting pain in the trapezius area, not really the shoulder. So the next evaluation that I do is for range of motion, and I always have them. I always compare it to the contralateral side so that I have a baseline of normal. So I'm checking forward elevation as well as abduction. And then external rotation. So this is a little bit, this is a top-down view. And so I'll have the patient put their arm at their side, actually both sides, and then keeping their elbows at their side, have them just turn the arm out. This picture down here, if they're having difficulty actually sitting, you can also have them lay down and do it as well. And so with the elbow and the arm here, you would have them check external rotation. So that would be with the arm coming down below the table and then internal rotation going towards the table. But I think it's easier to have them sitting and check it with the arm at the elbow, arm at the side. And then internal rotation, I usually will use spine levels. So I have the patient reach behind their back and see how high up they can go. And so just as a point of reference, the bottom of the ribs is about T12. If they can only make it to the sacrum versus the other, the contralateral side, they can go all the way up to their scapula, then that's a significant difference. And usually I'll note that in my exam. So there's many different muscles around the shoulder, and they all have very specific testing to do for strength testing. So for the subscapularis, there's two of them. One is called the lift-off test. So with this, the patient's putting the arm behind their back and just trying to push away. And the bottom one is something called the belly press test, where they're putting their hand on their stomach and trying to bring their elbow forward. So in this one, this is actually someone who can't do it. You ask them to press on their stomach and they can't actually bring their elbow forward. And then in C, it's something called the bear hug test. What they're doing is you ask them to grab their contralateral shoulder and hold on to it, and then you try to take the hand off. So in each of these, you're testing internal rotation. The infraspinatus, you can have their arm down at their side with their elbow bent to 90 degrees, and then ask them to push out against you. And supraspinatus testing is with, so the person in the yellow is getting tested. Their arm is up at 90 degrees, and they're turning their thumb down, and then you ask them to push up to the ceiling while you're trying to push down. So what I will tell you is that we have one set of the exam, which is the strength testing, and then the next set of the exam is provocative maneuvers, meaning that if these things cause pain, then it could potentially be a tear or bursitis or something like that. I will tell you, in someone who has a lot of shoulder pain, pretty much every test is going to be positive just because it's just painful in general to move the shoulder. But sometimes it's actually more important what's negative as opposed to what's positive. So the first two maneuvers, the Neer test and the Hawkins test, both of those are checking a rotator cuff pathology. The third one, cross-body adduction, that's something where in addition to palpating the AC joint, it's also checking for inflammation or symptomatic arthritis at the AC joint. That's actually just bringing what it says, bringing the arm across the body. And then the bottom two tests are checking for the biceps tendinitis, in addition, again, to palpating where the structure actually is. So for the near test here, what you're doing is you're internally rotating the arm and then raising it. And in the idea behind this maneuver is that you are trying to bring the rotator cuff under the acromion. And so if there's enough space, if there's no inflammation, if there's no tearing, that will be painless. But if there is inflammation or if there is a tear, then it's going to be painful. The same idea of the Hawkins test. You have their arm abducted to 90 degrees, and then you try to internally rotate at the shoulder. And again, the idea is to bring the rotator cuff under the acromion in that case. This is the AC joint test I was talking about. We sometimes also call it the scarf test. So if we go back to the anatomy in this area, the head would be over here. Oh, you have the clavicle, the acromion, and then by bringing the arm across, you're compressing the AC joint. If it's not painful, then again, it's asymptomatic AC joint arthritis or AC joint inflammation, depending on what the MRI diagnosis is. Labral tears are a little more complicated to check in the office. I would say the history with this actually is also very vague. It can sometimes be, I would say probably the most common scenario we see is someone who does an overhead sport or is throwing something. But again, all bets are off when somebody has a fall because really anything in the shoulder can be injured. This test up here, A, would be the one that if you were going to try this test, it's the O'Brien's test. What you do is, again, you have almost every provocative test for the shoulder. You're bringing the shoulder away from the body, usually to at least 90 degrees to try to make contact with those structures. So with this one, the arm you can see is lifted up to 90 degrees, or you have the patient lifted to 90 degrees. Again, internally rotate the arm. That's also a very common position to have the shoulder in when trying to provoke pain. And then as the patient is trying to push up, you're trying to push them down to resist them. The apprehension test is something that we see in someone who has a labral tear from a dislocation. So usually when someone has dislocated the shoulder, almost always they know it because the first time it happens, they can't get it back in themselves. They have to go to the emergency room, or there has to be another person who can actually push the shoulder back into place. So when a patient comes in and says that they feel that their shoulder is unstable, it's very important to actually drill them down and say, has your shoulder actually come out of place? Or if it hasn't come out of place to the point that someone else has had to put it in, sometimes if they're very loose jointed, they can actually get the shoulder back in themselves. But when someone says instability, you just want to clarify what that is, because true instability really is the ball popping out of the socket. So if that's the case, when the shoulder comes out of place, they will, I would say 99% of the time, they will tear the labrum in the shoulder joint because that's the fence that holds the shoulder in place. There are a couple different tests that you can do in the office to check. One is called the apprehension test. So actually, let me backtrack. If someone has just dislocated their shoulder, you don't want to do this test because the shoulder is still very unstable. Even though the labrum is torn, most likely, but also the muscles around the shoulder are probably spasming and also not helping to keep the shoulder in. So there is a chance that if you're too aggressive with doing this maneuver, you can actually have the shoulder come out of place in the office, and then you have to put it back in, which a lot of times it can be very hard to put the shoulder back in without sedation. So when you're doing the apprehension test, you don't want to get to the point where they feel like the shoulder is going to come out. You just want to elicit if they will even let them put that shoulder in that position. Because many times, if someone doesn't have true instability, you actually can't, or if they do have true instability, you actually can't even move that shoulder close to the position of fear because they just won't let you put that in because they know it's going to come out of place. So what you do in this test is you have the patient lay down. You usually do this in a supine position. Again, 90 degrees for everything here. So you bring the arm to 90 degrees, the elbow is at 90 degrees, and then you try to very, very slowly, basically externally rotate the arm. So you're putting it like this. So you're like this, and then you try to bring it back that way. What you're doing in that case is putting pressure in the front of the shoulder where the labrum is torn, so there's no restraint there. And so if someone has true shoulder instability, has a labral tear, again, they won't let you put their shoulder in that position just because they're too fearful that it's going to come out of place. If you're able to put their shoulder in that place and they have no qualms about it, it's most likely not a labral tear and not the shoulder's not unstable. And then what the relocation test is because the shoulder is coming out the front, you actually put your hand and push it back in, and then they feel relieved. Some other things that you can check are if someone doesn't have a history of trauma, but they still feel like their shoulder is unstable, sometimes that can happen in someone who's very ligamentously laxed. As an example, someone with Ehlers-Danlos syndrome. So some other things that you can check are something called the sulcus sign. So what you do with this is you actually pull down on their elbow, and the bony anatomy will change on the left shoulder because there's an increased space between the acromion and the humeral head. But again, you have to check their normal side to see if there's actually a difference. And then with the posterior apprehension test, this is a little harder to do in the office. Usually when a shoulder comes out of place, it's usually coming out the front. And so when you are trying to test for it, you're trying to push the shoulder out the front. In some cases, the shoulder can come out the back. That's probably the most common in someone who has a history of seizures. And if it comes out the back, you're sort of reversing that maneuver. You're putting a posterior force against the humeral head to try to see if it'll come out the back, or again, if it makes the patient nervous. These are a little more, I guess, finer tuning the exam, but just to give you an example of what we do in the office. And honestly, the time that we really get the best examination is actually when the patient is under anesthesia, because then they're completely relaxed. Most of the time, if it's somebody with a history of the shoulder coming out of place, they really don't want you to do much with it to elicit that feeling in the office. So what we test for in the office or in the operating room is, if you look at this picture down here, the shoulder in cross section is sort of like a golf ball on a golf tee. And so you always want that golf ball centered in the tee. But there's different grades of how unstable it can be. So the bottom one is a completely unstable shoulder. This is a true dislocation where the socket or the ball, I mean the ball or the humeral head completely comes out of the socket. And then the first one, that's less, that's the opposite end of the spectrum, where it maybe rolls a little bit out of the socket, but doesn't come completely out. And then number two is it comes out, but then will come back in on itself. So even within the range of instability, there's many different ways that people can experience how severe it is. Okay, so going back to rotator cuff disease, which is probably the most common thing that we see in general in an older population, there also is a spectrum of problems with this too. So the least severe would be just inflammation. So there are a couple of different words we use for this, either bursitis or impingement. And on the other end of the spectrum, the full tears, where the rotator cuff is completely torn. And this can be due to trauma, but we also know that's very common just as we get older. And in the middle, you can have a partial tear of the rotator cuff where it's not completely torn. So some very common complaints are either activity-related pain. If the pain is waking up somebody from sleep, that's something where it's probably a little bit more severe tearing. And then the strength testing is very important to check for weakness, because if there is weakness, that may be something where you would be a little more inclined to get an MRI before starting other treatments to look for a tear. So impingement, bursitis, tendinitis, they kind of all fall under the same umbrella. So what the idea is in terms of what's happening here is, if we're looking at this picture here, the head would be on the left. Everything that's tan is bone. So you have humeral head and glenoid, which is the ball and socket here, and then the AC joint. So the different layers on the inside of the shoulder are the rotator cuff tendon. So in this picture, muscle is red, and then tendon is the white part here. And then you have the bursa, which is a cushion on top of the shoulder. And so when there's no inflammation, when everything is normal, the shoulder goes through range of motion, and these are what all the structures. There's space for everything. when there is inflammation, as in the right picture on the right, what happens is the space available for things to move typically gets smaller because inflammation results in, what we see surgically is more tissue. So it's inflamed synovium or bursa, and that can be very thick tissue that doesn't really serve any purpose, but it just takes up space. And then what happens is when someone goes, what they're showing you here, the reason why all our provocative tests are with the arm abducted or elevated away from the shoulders, because that's going to close down the space in this area. We call it the subacromial space. And if you have a problem going on there, that's going to cause pain. For many years, I would say for decades, actually, there was a school of thought that the shape of the acromion contributed to problems with the rotator cuff. And if you look at this picture, this is looking at looking in the glenoid itself. So in this picture, someone's head would be at the top, the front would be to the left. And the main takeaway from this is the acromion has different shapes. So you can have one that's flat, you can have one that's curved, and you can have one that's a hook. It's just the way your anatomy is. There's no necessary rhyme or reason as to why someone develops one over the other. And so the acromion in this picture is this bone here. And so the idea previously was that if there was more of a hook, then that could actually dig into the rotator cuff. And again, like I said, it was decades that was believed. And so what that translated into was at the time of surgery, you would look for this bone spur and actually burr it down. There's definitely more controversy regarding whether or not that is a cause of the pathology. So it's something where there have been studies done on not taking the bone off, and it really hasn't made a difference in the outcome. So the pendulum is sort of shifted in terms of whether or not that's a problem. But that is one of the factors that led to this whole theory of shoulder impingement. So, like I said, the sort of least severe problem with rotator cuff tendons is impingement, tendinitis, or bursitis, things that are mainly just inflammation. And so what you're going to look for and what you want to get from the history is whether or not they've had any trauma. What the onset is it something that happened right away, or has it been going on for a long period of time? Frequently when someone has to do a lot of heavy labor, it will be a very insidious onset. When you check their strength, the strength to me is probably one of the most important things. Sometimes it can be hard to tell, like if they have pain, that can limit the strength testing. But strength is something you want to make sure you're checking on your exam. And then in terms of other complaints, the position of the arm that's going to cause pain will usually be if it's away from the body. Again, everything where the elbow is away from the body is also moving the shoulder away from the body. So that's going to give less space for the rotator cuff to move in, or any position where their arm is internally rotated. So that would be something where they're reaching behind their back. That can also cause pain. And then again, pain at night, keeping them from sleeping, to me, that usually is a little bit more, so something where I would consider getting an MRI a little bit earlier. And then if you make the diagnosis and it is just bursitis or tendinitis, you're not as concerned about a tear, these patients usually are very responsive to non-operative treatment. And that would be anything from physical therapy to NSAIDs, potentially work-related restrictions, or sports restrictions. And then very, very rarely, I will offer them a cortisone injection. And the reason why I say very rarely is because cortisone, of course, we all know it's great for pain. It's not good for the rotator cuff tendon or any tendons at all, actually, in the body, because, if you do one cortisone shot, it's probably fine. However, the more injections you do of cortisone around a tendon, you weaken the tendon and potentially make it more likely to tear. So I really, really try to save the cortisone shots if someone really can kind of get by without them. This is probably the one cause that's not a tear that causes a lot of pain. And so once you see someone with calcific tendinitis come in, you will never forget it because they're in so much pain. And this is something that pretty much happens overnight. So I would say usually the history is they've had maybe a little bit off and on pain, but they woke up one morning and they cannot even move the shoulder, almost to the point that you would consider, do they have an infection or something like that? Their pain is there whether or not they move it. And they for sure, when you try to examine them, they can't even move the arm. And so you will make the diagnosis from the X-ray. You only need an X-ray for this problem. And this is what you're going to see. So when we get an X-ray of the shoulder, here's a humeral head, here's the acromion. There usually is nothing in this space here on the X-ray because it's only tendon and bursa. So what this X-ray is showing is this whole calcification here is a calcium deposit that's actually sitting in the rotator cuff tendon. And you can sometimes see small ones on an X-ray that aren't a problem, but if they get larger, then they start to take up that very limited space and can be really painful. In terms of what the treatment is, it's usually not surgery, but it's usually also not just anti-inflammatories. It's usually just much too painful for Advil to take care of it because there is something structural sitting there. So the procedure that they can get done, and I would say they can either get it done in radiology or like a non-surgical sports medicine doctor can do this. That piece of calcium is very hard, but it can be broken up with a needle. So usually they'll get a procedure where the needle is actually almost like a kidney stone. The needle is used to break up the calcium deposit, flushed with saline, and then you do the cortisone injection. Their relief is almost instantaneous, but this is the one thing where you will make the diagnosis from the X-ray alone. So in terms of when do I get an MRI, if someone has had trauma and they fell on their shoulder and went from completely normal shoulder to very painful, unable to raise it, then I will definitely get an MRI because I'm concerned about a tear. Conversely, or additionally, if they haven't had trauma, but just have had this insidious pain that really isn't going away, and they're showing signs of weakness on my exam, I'll probably get an MRI also, just because I'm concerned about a tear in that case. And then the third one is when you've tried everything, the physical therapy and the NSAIDs, and it's still painful, then also MRI for the same reason. So in terms of rotator cuff tears, it's the most common shoulder condition that we see. What we do know is that as we get older, the rotator cuff will show tearing, whether or not you've done anything that is risky for one, meaning that either sports-wise or work-wise or trauma. And the reason we know this is because there's been ultrasound studies looking at patients, looking at one shoulder and actually both shoulders, showing that as we get older, there's a good chance of having a rotator cuff tear and a 50% chance that you actually have it in both shoulders. So in terms of if you have a tear, the next question usually is, well, how fast is it going to get worse? Is it going to get worse? Will it heal on its own? One thing we do know is that if you have a complete rotator cuff tear, it will not heal on its own. However, it doesn't always mean you need immediately to do surgery. And the key is whether or not that patient is actually having any problems with the shoulder. So if someone has an MRI and it shows very small tear, but they're getting better with physical therapy, their strength is actually pretty good, that one usually we actually will just monitor and not necessarily recommend surgery. If you look at this particular study here, what they saw was that if someone does not have pain, it will progress in size, but it's not very quick. But if they have a tear that is causing pain, that is something that's going to potentially get larger faster. And that's a reason to fix it surgically earlier. And then these two findings, these are MRI findings, but there's a difference in a tear with, a tear that is, I would say, not as serious would be one that hasn't retracted. So what I mean by that is that when the tendon tears, it is physically tearing off the bone, but it can tear off the bone and kind of hover in the area where it's supposed to be, or it can sort of move away from where it's supposed to be, like a rubber band just kind of springs back. And then on an MRI, you'll be able to measure, oh, this tear is 3 centimeters from where it's supposed to be, or 5 centimeters from where it's supposed to be. The problem with that is that as the tendon moves away from where it's supposed to be, it starts to scar in and it gets less pliable. So what happens is then when you do try to fix it with surgery, it sometimes is very hard to get back over to where it's supposed to be, or sometimes it actually won't even come back. So that's something where if you see that on the MRI that the tendon is already pulled away from where it's supposed to be, that's something where you don't want to wait too long to fix it, because the longer you wait, the harder it gets to actually sew it back together. And then the second finding on there is something called fatty atrophy or infiltration. What that is the tendons are the muscle connection to the bone. But if those tendons have been torn for a while, they haven't been getting the stimulation that they need. And then what can happen is that that muscle can turn to fat, and that fat doesn't necessarily turn back to muscle. So that's also something where if we start to see on the MRI that there is some muscle turning to fat, that's something where you typically want to fix it, because if you wait too long again and that muscle turns mainly to fat, then that's going to lead to persistent weakness, even if you do surgery for it. So this is what we actually see at the time of surgery. So what this picture is showing you here is this is the humeral head here, and this is the end of the rotator cuff tendon. If you contrast that to the picture below, that's a rotator cuff that's been sewn back together. So you can see you can't actually look in underneath the tendon anymore. So there's many different ways that we sew the tendon together, but they're all essentially the same. The idea is that we put stitches in the end of the tendon, but then you have to fix it to bone. So we fix it to bone through usually some sort of plastic or suture material. I would say less so metal as time goes on. And in general, in terms of how people do, in general, I would say it's overall relatively successful operation, but a very long recovery. So usually I would say it takes about a year for someone to really feel like they're back to everything. So the reason why it takes so long to recover is part of it is just biological healing. So when the tendon tears away from the bone, like we said, it doesn't naturally heal back to the bone. So with bringing the tendon over to the bone, you're trying to force it to heal back biologically. And so what we know is that that actually doesn't always happen either. So there are things that we can use to try to enhance that healing. There's different patches that we can put on to try to get the tendon to heal back. But that's partly why it takes so long to recover from a rotator cuff surgery. So probably one of the second most common things I see in the office is frozen shoulder. And so with frozen shoulder, this is the in the blue is probably the most important thing to take away from that, is that the patient's active motion is the same as their passive motion. So you ask them to move their shoulder, and then you try to move it, and there's no difference between the two. They're stuck. Versus if someone has tendinitis, they can maybe move their shoulder a certain amount, but they have to stop because it hurts. But then if you can move it further if they relax, because it's not as painful when you do it. The typical scenario is it's insidious. There's not usually any trauma. There can be trauma, but not necessarily. And then there's 3 phases. So the first phase is very painful. They have pain even at rest. And that's the freezing phase. The shoulder also starts to get very stiff. The second phase is the shoulder is frozen, and so they are stiff at that point, but it's not that painful. And then the third phase, they sort of thaw out and the motion gets better. At the time of surgery, and I would say it's not that common actually to need surgery for it, but you can see the difference between the two. So on the left, that's a completely normal shoulder. Everything is nice and pink and healthy. Look at the same view on this one. You really can't see anything. It's just a lot of inflammatory tissue. It's red. It looks angry. So what's happening with frozen shoulder is that the capsule around the shoulder, one of the deepest structures, is getting inflamed. And that can happen. It is considered an autoimmune condition. And it can happen more likely in someone who has diabetes or thyroid disease. So that's also a really important thing to elicit from their history. It does not need surgery, almost never needs surgery, but the pictures I showed you, obviously are someone who did go on to need surgery. It is self-limited, but it can sometimes take 1 to 2 years to completely resolve. So that's really the important distinction to make with these patients, is that it really is just time and physical therapy, maintaining their motion, that sort of thing. But it is something that will get better on its own. You can very occasionally consider a cortisone injection for this, but I usually do not unless the pain is so much that they cannot even do the physical therapy exercises. So it's pretty rare that I would do the cortisone shot. It doesn't change the course of the process of the disease. It is only for pain, and so usually oral NSAIDs are fine for this. And like I said, it's very unusual to actually need to do surgery for it. Okay. I'm going to do one case and I'm happy to take any questions. So the 55-year-old female who's had several months of right shoulder pain, she had no trauma, mostly with activity. She does have pain at night. She has difficulty with function. And then one of the most common things that people say is that it hurts when they try to reach for things or if they try to put their bra on. And her history is positive for diabetes. So on her exam, she has limited elevation. Usually forward elevation would be about 170 degrees. She's unable to internally rotate. And again, I said that hallmark, her active and passive range of motion are the same. And she does have good strength. So the next step would be NSAIDs, physical therapy, injection, X-rays, MRI. So in terms of imaging, usually we'll do X-rays first. And the reason for that is, like I said, there are diagnoses you can make from the X-ray. And so on the left, that's a healthy shoulder joint. On the right, that's arthritis. And so you can certainly have shoulder arthritis and have a similar history. Again, like I said, calcific tendonitis, you're going to see the diagnosis on the X-ray. And honestly, most insurance companies want the X-ray before you get the MRI. So a lot of the times we'll see these patients and they've already gotten an MRI. And so here's like a very common report that we get: partial rotator cuff tear, maybe some impingement. In this case, the MRI really isn't that helpful because clinically, we see that the patient has frozen shoulder and you're not going to change the management in any way. It's just, it may give you some more information, but it's not really changing what the management is. Okay, happy to take any questions. I know I went through a lot of material there.